Bismillahirrahmanirrahim. Today's topic is diagnostic criteria, screening and glycemic targets. Diagnostic criteria of diabetes, screening of diabetes and glycemic target. My name is Ashraf Fawad. I am consultant diabetologist and research consultant at Bakai Institute of Diabetology and Endocrinology. At the same time, I am serving Bakai Medical University as Dean Faculty of Basic Medical Sciences, Professor and Chairman of Biochemistry and Research Department, Joint Secretary of Diabetic Association of Pakistan. So it's an honor and pleasure for me to be here and to share my 20 years of experience with this institute with you. I consider and as I am informed that you people are primary care physicians and you are the backbone of our healthcare system with the bulk of community from which the people are seeking advice for their day-to-day routine problems and concerns. Diabetes, when it is considered as a 33 million people with diabetes in Pakistan, I am sure my colleagues have given you the insights about the epidemiology of type 2 diabetes. So today's learning objectives, after the 30 minutes of learning, my objectives are very simple, that you will be understanding what is the exact diagnostic criteria to diagnose hyperglycemia. I will be explaining the term hyperglycemia and then what are the tools to diagnose it, how to screen for hyperglycemia, and once someone is diagnosed with hyperglycemia, what will be the targets of its control. So coming to all these things one by one, diagnosis of diabetes is through fasting plasma glucose. Here I would like to clear the hyperglycemia. Hyperglycemia means anything that is more than normal. So abnormal glucose tolerance, another term in which diagnosis and impaired fasting glucose, impaired glucose tolerance, and sometimes it is called a pre-diabetes term which is non-scientific, but all this is called hyperglycemia. When we focus to the diagnosis of diabetes, it is on the fasting basis. Once someone is having some symptoms or anything that you consider that your subject or person should be screened for diabetes, fasting plasma glucose, postprandial blood glucose level. It can be through 75 gram glucose load or through HbA1c. This is a relatively, I must not say a newer technique, but still it's a bit tricky. I will let you know in my subsequent slides. So what are the criteria for the diagnosis of diabetes? When someone comes to you and it has the blood glucose run in fasting and the level is equal to or more than 126 milligrams per deciliter, it is taken as fasting hyperglycemia in the range of diabetes. Obviously, fasting is defined when there is no caloric intake for at least last 8 hours, but on the whole, considered that if someone is grossly hyperglycemic, the duration of fasting doesn't matter, but for the sake of guidelines, the duration of fasting should be 8 hours to take the fasting plasma glucose levels, and if it is more than or equal to 126 milligram per deciliter, it will be taken as diabetes. Now, on the other side, if someone is in the postprandial state, that is, if he or she has taken some meal and or if 75 gram glucose load is given to that particular subject after fasting and the level is more than 200 milligram per deciliter, then it is called hyperglycemia or diabetes in postprandial state. So any level either in fasting or in 2 hours plasma is in the abnormal range that are mentioned in the slides, they should be considered as diabetic along with the symptoms. If symptoms are not there and incidentally some subject has got that particular reading in fasting or in 2 hours postprandial glucose, then that reading must be confirmed after few days time with a fresh sample. And if the reading remains the same in the higher level, then the diagnosis is confirmed, or if the readings are conflicting, then the 75-gram glucose load must be repeated after few days time. HbA1c, as I told you, is also taken as a diagnostic tool, and nowadays it more because of its convenience, that fasting state is not required, and if the level is more than 6.5%, equal to or more than 6.5%, then it will be considered as diabetic. But here I must emphasize the limitations and some other points mentioned for HbA1c. This has been proven by the data from Pakistan, the National Diabetes Survey of Pakistan, which is done by BIDE and Ministry of Health, that HbA1c, the sensitivity and specificity to diagnose the diabetes is not that accurate. Plus, HbA1c is very much costly as compared to the normal fasting plasma glucose or postprandial glucose level, and HbA1c is affected by many medical conditions. In it can be altered and it can misguide for the readings of diabetes. From the day-to-day basis, we see the readings that are at the borderline, that are in the impaired glucose tolerance with HbA1c, but on the other side, the fasting plasma glucose or the postprandials are normal. That creates confusion in the mind of subject who is being tested or the physician. So the message from the platform of BIDE is, if you want to screen someone for diabetes, go for the fasting plasma glucose level and 75-gram glucose challenge test. When the subject is having a classical symptoms of hyperglycemia, you must be knowing by now, understanding the pathophysiology of that includes polyuria, polydipsia, unexplained weight loss. Here I must emphasize that for type 2 diabetes, it can be silent for any levels beyond 300, 400, even 500 milligrams per deciliter, and subject remains silent from the symptoms point of view, and still the levels are high. So for type 2 diabetes, symptoms are important, but in my slides that are coming now further down, I will be letting you know how and when the people with the risk factors should be screened, rather than to develop symptoms first. When the symptoms are developed, it means the body is getting the adverse event, the adverse effect of hyperglycemia, and the effect of hyperglycemia started already and are coming. So early diagnosis is important in order to avoid complications of diabetes. This slide, I just want to focus you the intermediate level of hyperglycemia. By now, we are now clear that what is the abnormal glucose level for diabetes. Here I want to emphasize that in the fasting state, if the blood glucose level is between 110 and 125, it will be considered as impaired fasting glucose, and less than 110 is considered normal in the fasting as per the WHO guidelines. IDF, International Diabetes Federation, says it 100 but we do not want to be in the conflict. WHO criteria is well accepted in Pakistan. So will take it 110 to 125 as the impaired fasting glucose, and in the postprandial state between 141 to 199 is the impaired glucose tolerance. This is the intermediate hyperglycemia, or you can say it borderline diabetes or pre-diabetes. Here, the importance is why it is called intermediate hyperglycemia, or why it is not normal. Because the studies have suggested, epidemiological studies have suggested that the problems started even at this level, the microvascular complications and to some extent the macrovascular complications started at the impaired levels, and this level should be identified early, not only to avoid complications but also in order to delay the progress into the over type 2 diabetes. This is another important tool which is developed by Bakai Institute of Diabetology and Endocrinology. The credit to its lead author, Dr. Musarrat Riaz and team, how to screen the people of Pakistan in origin that are having the risk factors. There are only 3 questions, and if the total score is 4 or more, your risk is there, and you must get tested from your doctor for fasting or postprandial glucose level or through oral glucose tolerance test. These risk factors are age, waist circumference, and family history of diabetes. When it comes to the family history of diabetes, it is the relative waist circumference 90 centimeter, less than 90 centimeter in male and less than 80 centimeter in female, and age cutoff criteria is 40, then 40 to 50 and greater than 50. The scores are there. If the score is more than 4, this is a really simple tool which can be used in the community to screen the high risk population. If the score is more, the population is high risk, and all these subjects who are having score more than 4 should be screened for diabetes to have early diagnosis either for intermediate hyperglycemia or type 2 diabetes. Now, for the sake of science and guidelines, frequency. On the whole, being Asians, being Pakistani is itself a risk factor for type 2 diabetes. So, we should not ignore the part of screening from our life, but there are certain guidelines that should be followed accordingly, and the subjects who are already diagnosed with pre-diabetes or intermediate hyperglycemia, either on fasting or post prandial level or through A1C, they should be tested at least yearly, on a yearly basis. And women with gestational diabetes after the delivery should be tested on yearly basis. These are the guidelines, but in our clinics, we usually advocate the lifestyle modification, tree changes, walk, to all these subjects, and a frequent monitoring of the levels is advised. But at least once in a year, they should screen themselves for the diabetes. Next is screening for type 2 diabetes or pre-diabetes in children and adolescents. This is another problem which is getting more and more in this part of the world. We are now seeing boys and girls with type 2 diabetes in the age of 20 or even in teenagers. So, it's really very important if the young children are overweight or obese or have any of the additional risk factors, for example, having family history of diabetes, if the maternal history of diabetes for GDM is also there, family diabetes in first or second degree relative is there, then these children should also be screened, not only screened, but also they should be focused for the management of the risk factors. A1C, HbA1c, as I told you earlier, that this is a test which is more important to assess the prognosis of diabetes. When it comes to the diagnosis, it has limitations, sensitivity and specificity is not that much. Even during the prognosis, we have certain limitations that we face during the assessment of the control of type 2 diabetes. There are of HbA1cs because of the certain biochemical factors, hematological factors, the lifespan of RBCs. There are certain interferences with vitamins and some other biochemical factors, maybe hyperuricemia and other pathological conditions that interfere with the assessment of HbA1c. So the point of I want to emphasize on this point for the primary care physicians, please focus on the blood glucose readings that a patient or subject is taking with him or her. These readings are more important, that can be supplemented with HbA1c, but the main focus you should be doing on the blood glucose reading that the patient to you. And the decision should not be made only on HbA1c or with a blood glucose reading that is casually checked during the visit, during the clinic. Subject must be performing its blood glucose monitoring, SMBGs, blood glucose monitoring chart should be properly assessed, and accordingly the decision should be made. So HbA1c level in diagnosis, in prognosis should be taken into consideration with all the due limitations. Now, practically speaking, HbA1c and average blood glucose, it's not like that. Again, another limitation of HbA1c, the variation in a blood glucose level. If a subject has a hyper and hypoglycemia, the HbA1c can be good, can be bad, or can be normal. So it cannot guide you in a simple way as mentioned in this slide. So we must focus again, the emphasis is on blood glucose level, because HbA1c is just giving you the average blood glucose that is being recorded by RBCs. Here the hyper and hypos will be taken into consideration through the blood glucose monitoring. Now, the final part of this presentation is what are the glycemic targets for the population. There are many guidelines that tells us about the targets of blood glucose level. In Pakistan, we have also published guidelines with the name of PROMPT. We agree that the targets should be individualized, and during the lifespan of the duration of diabetes, it can be changed and it can be adjusted. For example, if a subject is diagnosed with a very high HbA1c glucose levels, the target cannot be the one which is the ideal HbA1c. And if the subject is diagnosed with a relatively less higher, the target can be different. In general, a adult to avoid complication should be given a target of A1C of less than 7 for a preprandial glucose level of around 100 milligram per deciliter, and postprandial level should be around 150 milligrams per deciliter. Now, this is, we are talking about a subject with middle age, without any complication, without any handicapness, and without any other risk factors, cardiac or any other risk factors. When it comes to the risk factors, renal involvement, cardiac involvement, these targets are individualized further, and during that time, now the importance to avoid hypoglycemia, especially when there is autonomic neuropathy, will be more important. So slightly relaxer targets will be given to those subjects when complications are already existing, in order to have acute life-threatening complications of diabetes. I'm sure that you will be people will be having a complete lecture on gestational diabetes. The diagnosis for gestational diabetes is very different from the normal one, where the impaired glucose tolerance is also considered as a gestational diabetic. The targets for gestational diabetes is also stricter and tighter, where blood glucose fasting level should be less than 95 blood glucose, 95 milligram per deciliter, and 2 hours should be less than 120 milligrams per deciliter. So these are the references from where you can read the guidelines further. We are available here for any future queries or correspondences. Thank you once again for your attention. Assalamu alaikum.